Welcome to this UCL lunch hour lecture on dental implants and Hollywood smiles, advances and pitfalls. My name is Stephen Porter. I'm the director of UCL Eastman Dental Institute, and it's my great pleasure to present today's speaker, Professor Lambis Petridis. Lambis is the professor of Prosthodontics of UCL Eastman Dental Institute, and he's also the honorary consultant in restorative dentistry at UCL Eastman Dental Hospital. Now, Lambis is extremely well trained, and he's a highly respected academic in prosthodontics. He did his initial training in the University of Thessaloniki. He completed advanced training and a PhD in prosthodontics, and acquired a Master of Science from Tufts in America. And he completed a PhD in Thessaloniki in Greece. So he is a seriously good player as regards this subject area. Before I begin, or before Lambis begins, I wanted to let you know that we have, at the end of the lecture, some time for questions. And if you wish to submit questions for this, we're going to use the platform called Slido, sli.do. And if you go into that on your web system and you enter the code #dental-implants, you can upload questions for that. I'll now hand across to Lambis to commence his lecture. Thank you, Lambis.
Thank you very much, Stephen. Let me just share my screen. So thank you very much for the invitation. I think this is a very pertinent topic in the minds of a lot of people globally. So I will try to demystify some things for the general audience in the next few minutes. And listening to Stephen's kind introduction, I want to say that I'm coming with no real conflict of interest. So I don't work for any company. I can talk based on my knowledge and clinical experience. And as Stephen said, I have a number of hats talking to you. One as an academic and as a clinical academic at the university. Also as an honorary consultant in an NHS dental hospital, which is a public service. And then, of course, as someone who does practice in private practice. And I think it's important because seeing all these three aspects of clinical academia is important when you talk to people, because some people will go to private practice, some people will go to a public hospital or the public health system to get treatment. I'm also, as you heard, a prosthodontist, and some of you may wonder what a prosthodontist is. So we're all dentists. I am a dentist. I take care of my patients' general oral health needs. However, I have this specialty which is called prosthodontics. And essentially, a prosthodontist is the recognized expert in terms of tooth replacement, and sometimes not just tooth replacement. We can replace tissues like lost gums, lost bone with artificial materials. And of course, reconstructing teeth like smile makeovers or improvement of aesthetics. So that's what a prosthodontist does, amongst many other things, the main of which is treatment planning and almost like doing an architectural plan of what needs to happen in a mouth. So these are the topics I'm going to touch upon in the next 40 minutes or so. So a few definitions, which I think are very important. Talk about why we talk about bright white teeth, what is the evolution of the smile, and then the effect of social media, which is a big aspect in all of this. Of course, I will talk to you about the advances in smile design and tooth replacement, as well as the advances in dental implants. And as my title denotes, I will talk about the problems, because there are problems behind the scenes, and sometimes people don't want to talk about these problems, but there are pitfalls that you have to be mindful of. And I will end my presentation talking about this concept of shared decision making, understanding that from a patient perspective, and also understanding the long-term maintenance that is required for some of these treatments. So let's start with some definitions. First of all, a dental implant. For the last probably 30 to 40 years, 50 years, when we talk about a dental implant, we talk about a titanium screw, which is pretty much a foreign body, an implantable medical device, which through a surgical procedure we put into the bone, where you used to have a root of a tooth which is lost, and then with some time and some biological principles, this screw also integrates, it becomes ankylosed into the bone, and that allows us then to create, as prosthodontists, as dentists, some artificial crowns, which we screw, literally use screws to put these things together. It's all engineering. And put the crown on the implant, so you have something that looks like a tooth and feels like a tooth, and it's made out of different materials, most commonly porcelain. Now, Hollywood smile. Hollywood smile, as we all know, is characterized by white, straight teeth, and is really a very complex phenomenon involving social, cultural, scientific, and technological changes that started to happen in the early of 20th century. It did start with the development of the film industry and advertising, but in terms of the dental industry, when orthodontics came into play and what we call cosmetic dentistry, it kind of took off really big. So how did we come to talk about a Hollywood smile? If we look at history, and it's important to look at history, if you look from ancient times to the early 20th century, self-control and closed mouth were the characteristics of the upper class. You will never see a portrait or a sculpture from ancient Greece or Egypt of somebody smiling or showing teeth. That was not how you were supposed to be. So laughter and emotion were associated with the working class. There was a brief period of a revolution that happened with the French Revolution during the Enlightenment. And at that point, the culture of sensitivity became acceptable. So showing emotion, showing laughing, crying became publicly accepted among the elite class. And that prompted some artists like the one you see here in France to start painting pictures of people and portraits with a slight smile and slightly starting showing teeth. But that was suppressed. It was a very brief parenthesis in history. So we went back to where we were before. That started to change with the invention of camera. Now, Kodak Eastman, who is also the benefactor of the Eastman Dental Institutes around the world, and the one that I work for, and the start of movies in Hollywood, California. So at that point, actors started showing more teeth. But coming out of the First World War, even actors had crooked teeth, black teeth, discolored teeth, missing teeth, teeth with decay. And they were going to this very clever dentist in California called Charles Pincus, and they were saying, "No, dentist, can you do something for me? I have to go to the set and shoot a movie tomorrow." So he had a very clever invention to start gluing some white pieces of plastic on their teeth to make them look white. And those were the first laminate veneers. I mean, Charles Pincus invented them in the 1920s. And then, of course, from silent movies and black and white, we went to sound and color. And you see some of the artists that some of you, maybe the older people, might know them. I consider myself to be in that category, so I know these artists. The younger people may have seen them just in TikTok or clips, but they're all famous artists, and you start seeing teeth, white, bright teeth, and that's when the Hollywood smile kind of took over the world, because they had Hollywood started to export movies globally, and it just took the world by storm. However, the dental aesthetic aspect is not the same for all cultures. So in Asia, we have the so-called blackened teeth, when people used to put and still put charcoal and paint their teeth to protect them, and they feel proud for doing that, and they smile. Or the yaeba teeth in Japan, where a sign of youthfulness is actually having slightly crooked teeth and canines, the eye teeth, that are slightly pointy, sometimes too pointy. They actually do procedures to make them very pointy. Or the grills teeth in the hip hop culture of different artists. I mean, you can see here Katy Perry and Kanye West, which you may or may not have seen. Obviously, the younger generation knows Kanye West. He replaced his own set of natural teeth with titanium dentures. And that's a big thing in hip hop culture. And of course, also coming from a European perspective, I think although we've been taken by storm from Hollywood, and many people in Europe also demand white, bright teeth, the European culture is more in favor of a natural looking tooth. So there are differences in culture. Now, of course, needless to say that there is a huge effect of social media, especially in the last few years, and all these platforms that we know and we probably use, but also OpenAI, everybody talks about OpenAI and generally artificial intelligence. And I think we all know that artificial intelligence can actually create any image, any video you want on demand, and it will generate it, and it's actually fake. So that also has played a big role. So the first thing that has happened, as we know, is that social media has had significant effects on body image and self-esteem. That applies to dentistry and smiles as well, because smile is a huge part of how we feel and look and how other people perceive us. And then the fear of missing out. If your friends are having Botox and fillers and veneers and orthodontics and they look so much youthful, then you fear that maybe you should be doing the same as well. And you have this peer pressure and social media pressure. Also, as we know, we have this culture of immediate gratification. Everything yesterday. I want everything done yesterday, which is a bad thing for us because in medicine and dentistry, proper treatment needs to respect biology, and biology and biological processes need to respect time. And sometimes some patients pressure us and they say, I'm getting married next week, or I'm going on this trip, I need this by tomorrow. And it's not so easy, it's quite challenging. And of course, needless to say, that the same way that we have fake news for many, many years now, to the detriment of societies, we also have fake pictures, because even the things you see on social media, regardless if it's dental or non-dental, they are quite heavily filtered sometimes, and we don't realize that. So there have been some articles like this survey from the Middle East published very recently, showing that dentists have been affected by social media because the patients being affected by social media go and pressure the dentist to have white teeth, Hollywood smile, veneers, whitening, Invisalign, etc., even though they might not need them. And then also dentists post these things online because they have to kind of advertise, they feel pressure to do that. And also they feel that they have to do things. And that's why you see some articles written by some eminent people of, let's say, aesthetic dentistry globally, where they kind of try to put a hold on dentists doing over-treatment of patients, either with porcelain veneers or even composite, which is considered a more kind material, but still there is a lot of over-treatment out there because of the pressure of social media and patients. But let's talk about the advances in smile design and tooth replacement. Yes, we can take a smile and through some in-the-display treatment, and of course, prosthodontics at the end of the day, what I do, we can create a nice white, bright smile with straight teeth. And yes, we can do many things because we've had significant advances in dental materials over the years. So both in the direct composite resin, so the white fillings, as you would know them, or porcelain, or else we call it ceramics, or some hybrid materials, which is a mix of these two. There's been a lot of new materials. What I want to point out for the audience is all materials have advantages and disadvantages, and not all materials are suited for each individual patient. So please don't go to a dentist with a preconceived idea, I want porcelain veneers because my friend had them or I saw them on TV, because they might not be suitable for you. What has changed the way we work also is what we call minimally invasive and adhesive dentistry. So we try to preserve more of the tooth structure, not grind teeth, in other words, as much, and the aspect of digital dentistry, which I'm going to show you in a few minutes. So we can take patients who were born without some of their teeth. This is actually a Greek word called hypodontia. And in a very conservative way, we can replace these teeth here with a conservative resin bonded bridge or with dental implants and give back the smile. Or we can do a larger reconstruction of, let's say, failing old crowns and some recession of the gums and convert that to a more aesthetically pleasing smile. So we can do all that, and we can even change the smile of people who have crowded teeth and they normally require orthodontics, and you try to persuade them to have orthodontics, but they just deny and they want something else. With prosthodontics through restorative treatment and with the help of some diagnostics, of course, proper consent and veneers, we can straighten the smile prosthetically. Or here with people who have gum disease and they've lost some of the gum and they form these so-called black triangles, as we call them, which can be anesthetic on the smile, especially if they smile wide. We can very quickly and in a conservative way, without even touching the teeth, use composite resins, the white fillings as we call them, again, through a diagnostic phase and careful planning, and restore back the smile without even anesthetic. Or a patient who has spacing, diastemas, and again, refuses to have orthodontics, although they come with a newspaper picture and they say, this is how I want my smile to be. And we explain that really, if you want this kind of smile, ideally, we want to move your teeth, have orthodontics, and then do some restorative dentistry potentially, but they say, no, I do not want orthodontics. And then we go with some conservative treatment with some porcelain veneers, again, more additive rather than grinding teeth. And we can go from this situation with the diastemas to something more aesthetic for that patient, mimicking what they ask us to do on the picture they brought in the first place. And the same thing with discolored teeth. Here is a case that has multiple problems. It's not just the discolored tooth, it's also the tooth position. But again, through some diagnostic phases, some planning and execution, we can create a look that feels and looks like the natural teeth. And of course, this happens also with the help of great dental technicians. We have another big category of patients who have literally destroyed parts of their teeth through erosion and wear. And that's because of acids acting on their teeth. That's a big category of patients. And acids come from two directions, either intrinsic, so coming from the inside of the body, which means people may be vomiting because they have eating disorders or because they were former alcoholics, or because simply they have a very badly managed or mismanaged acid reflux, so indigestion. They can have chronically these kind of lesions and destroy all the enamel and the teeth. Or it could come from acids from the diet, which means acidic and sport drinks like Coca-Cola, Fanta, all these fizzy drinks have low pH, they're very acidic, and if you abuse them and drink a liter every day for many, many years, you will end up losing a lot of your enamel. And again, either through a very conservative way, just adding composite, or through porcelain in different categories, we can replace the lost tissues. We can obviously give back the aesthetics and the function, but also protect the underlying tooth. Of course, the other big difference that has been made in our lives as dental professionals is digital dentistry and digital workflow. So literally what we do is we digitize the patient and we digitize the teeth through the use of technologies with scanners, where we create a digital model of the mouth and then do some more processes. So there are three processes. One is to actually digitize the model or the cast or the impression of the patient, make it digital from analog. Then we sit by ourselves or with our dental technician on a computer, on a specific software, and we do what's called CAD, so computer assisted design. And we design the different dental prostheses. And this is one of the greatest tools we have. And then at the end, the technician can actually manufacture with different digital technologies the final product. That's the CAM, so computer assisted manufacturing, either with subtractive techniques like milling or through additive techniques like laser sintering, 3D printing, just to name a few. There are quite a few techniques. So this is an example of a scanned patient's mouth. You can see the upper teeth and the lower teeth. But what's good for me is that I can now sit in my own time, also with my patient, analyze the pictures, zoom in, zoom out, show things that maybe it's very hard to show otherwise, even through a static picture. Also, look at the bite relationship. But another thing that I can do is I have the scan in the patient record, and if I see this patient again after 1 or 2 years, I can rescan them, superimpose these files, which are called STL or PLY files, and actually look for changes. The algorithm will give me the changes in tooth position or wear, and we can monitor things prospectively. This software can also show you the bite, where the patient bites more, where you might have to adjust things, although it's not as accurate as true reality. You still have to use some analog ways for that, but it does give you a good idea for that as well. So it's a great communication tool and also planning tool, as you will see in a few moments. So part of planning is also what you might have heard, smile design, but here we have the digital smile design. So we can do a smile design in an analog way, and we do it on many occasions still, but there are now apps or software where we can actually take the different pictures and scans from the patients and mimic on a software, on a computer, the final result before we show it to the patient. And that's a great enhancement in terms of communication. So this is an example where my technician can send me a CAD file, and this is actually me working and checking what my technician is planning. I'm taking the different layers, and this is a bridge that my technician is planning. You see it in green, and I see whether it's at the right position that I have asked in my prescription, and I check it from different angles to see if I'm satisfied, and then I will give the okay to my technician after I've checked on this digitally to 3D print or mill. As you will see here, there will be a cast 3D printed from this file, and there will be a prosthesis, which in this instance, it was milled, and I can deliver it to the patient. So here's an example of a quite severe wear case because of acid erosion. And as you can see here, we have a lot of damage that we have to correct. And again, that's where the diagnostic is so important. By using digital technology, again, I work with my technician. This is again me playing on the screen and manipulating different files which are now superimposed. So the wax up where the teeth should be, which is what you see, is superimposed, and I'm taking it out as a translucent layer now, and I can see the diseased teeth underneath. And then I can put back the layer of my diagnostics where the teeth should be. And that allows me not just to look things like the bite, but also I can see how much I have to layer. I can measure things very precisely on a screen before the patient even sits on the chair. So it's almost like making an architectural plan for the patient, and that's my job as a prosthodontist. And I can plan for my materials, I can plan for my techniques, I can plan exactly what will happen, and I can actually show it to the patient. So for me, this is one of the greatest tools when I use digital technology. And this is the patient before, and slowly with different materials, both composite and porcelain, reconstructing this mouth and obviously giving back the function, the aesthetics, and also protecting the teeth below. And this is two scans, the scan of the teeth before we did anything. As you can see, the pitting, corrosion, and erosion. And this is the scan after everything was done, the post-op scan, and you can see the clear difference. Of course, as a clinical academic, we are publishing a lot on this. There's not time today to actually go through all the publications, but digital workflows is something that we're very proud of doing, both at the Eastman Dental Institute and also the Eastman Dental Hospital. So all my students are working for their patients with these workflows that you see for the NHS patients, and we're proud of doing that in our Rockefeller building. And of course, we publish a lot, and we've continued to publish, and we have quite a few publications in the pipeline coming up. But let's talk a little bit about the advances in dental implants. Dental implants started many, many years ago, but really these root form implants that look like a screw started 30 or 50 years ago. And they first started for people who had no teeth. So people who were losing their teeth, were going to have dentures, they couldn't tolerate a lower denture. And we used to put 4 to 6 dental implants, and then the technician will make a prosthesis. So what you see is plastic teeth, screwed. You see 4 screws, 4 screw channels with the screws, screwed on these 4 implants so it doesn't move. And this would give back function and aesthetics to the patients. Usually they had an upper complete denture, so no teeth. These are all artificial teeth of a very old patient. That's why you see them more yellow. After that, in the 90s, we started doing tooth replacements with implants for few missing teeth, so not all the teeth. So in this example, 6 posterior teeth on the lower arch. And then at some point, we started doing tooth replacement with dental implants for just 1 tooth. And if that 1 tooth is in the front part, is right on the smile, and especially if you have all these, as you see, strange characterizations on the adjacent teeth, it's really part again of the artistry of a dental technician, not just a prosthodontist, but you have to work with a good technician in order to give back what looks like a natural tooth. It comes out of the gum like a natural tooth. You really cannot distinguish it from the rest of the teeth, but it's actually a dental implant. So now we can do single crowns, fixed bridges, like a 3-unit bridge that you see, or even, as we call them, fixed complete dentures, which means we can replace all of the teeth and part of the gums that have been lost and the bone prosthetically, either with porcelain or composite materials, but imitate nature, in other words, with prosthetic materials. And you can see here on 6 implants screwed down. But also, another thing that very few people talk about is that there are millions of people who have dentures. They have no teeth, they just have dentures. And they have big problems functioning with those dentures because they move, they come out, even if they're properly made. And we can use very few implants, 2 to 3 or 4 implants. 2 implants is the minimum and the gold standard, and actually have some attachments that clip on the dentures, like you see here. And that completely changes the quality of life for these patients, just with a couple of implants. Here's an example of a patient replacing upper and lower teeth on one side, and you can see the dental implant crowns on the cast, on the model, in the lab, and then in the mouth. As you can see, we give back the aesthetics and the function, and these are the screws that connect the whole thing on the dental implants, and then we close this access with a filling. And this is another case where you have some implants and a tooth as a crown in between, and this is the result after 11 years. Obviously, I can show you many cases up to 20, 25 years in terms of my practice. And if you do it properly and you have proper maintenance, for which I will talk later, the results can be quite good. A patient that doesn't really smile, and why? Because they have missing many teeth, and also the remaining teeth are failing. Again, we can convert with dental implants, a number of dental implants, and give back smile, function, and aesthetics. But again, however, as I'm going to talk in a few minutes, there are some caveats to that, because there are complications, and people have to be aware of the cost and long-term maintenance needs that are involved in these treatments. And another case here where you have a tooth that has fracture, you see the root, and we have to place a dental implant, as we do here. And then this has to be restored. And again, we try to make a prosthesis that looks like the adjacent teeth, quite natural. So we're not changing the whole smile because the patient really needs one tooth, and it has to merge with the rest of the teeth. And this is what I meant before for people with dentures. You can see either 2 implants and different kinds of attachments, or a clip and a bar, as we call it. It allows the denture to clip with a male-female attachment. And that, again, makes a huge difference in the quality of life of patients, especially elderly patients. Now, another big revolution that we've had for many years when we use digital workflows is actually the planning of the implant. So the planning of the placement, the surgical placement of the implant. And this has been going on for many years. And I'm going to just show you a quick video which was produced for our unit by our staff, and just shows you how we can merge files. So we can merge the x-rays, we can merge the actual scanning of the patient's mouth, and then we can visualize things like a nerve. This pink line is a nerve that we should not touch, and actually virtually then on a screen place the future implant that we're planning. Not only place it, but actually see it from 360 degrees. Look at where the adjacent teeth are, so we avoid hitting them or traumatizing a nerve or some artery. So planning it very carefully on a computer, and then that allows us, once we're happy, to create a surgical guide, which is something that we'll put in the mouth and guide us to actually place the dental implant. And we can do it in different aspects of guidance. But as you can see, we virtually pretty much know where the implant will go. And then if we're happy and we have the safety margins in place, we can actually produce the surgical guide, as you will see here, which is 3D printed. And with that surgical guide, we go, we see our patient, and we're pretty confident most of the times, if this is done properly, that as you can see, the guide is being done here. We can be very confident that the placement of the implant, the surgical placement, will be very precise, avoiding any surgical complications like hitting the adjacent structures. So I think, again, that's another revolution that has been going on for a while. And then the next phase, of course, once the implants are ready, as you can see here, you can kind of tell where the implants are, because we have special components that we screw on the implants, and we actually scan again with a scanner, and we make this digital to take it to the lab to go to the next phase, which is actually making a prosthesis. So we actually have a virtual patient with different aspects of the patient scanned. We can scan faces, but I'm not showing you that today. So we can scan and digitize the whole patient. And of course, as with digital workflows, we have been doing a lot of research in the department over the past few years on dental implants, many aspects of dental implants, from complications all the way to tribal corrosion and bone loss around dental implants. So quite a few publications which we're still doing and still having some work in the pipeline. Now, I did promise that I'm going to talk about pitfalls, because it's not all happy and problem-free. So the first thing to say, and everybody has to understand this, is that tooth structure, the teeth, cannot be regenerated. So if you have decay, if you have tooth erosion, if you have problems like that, then that is an irreversible damage, at least in 2024. Maybe we are going to be, and actually we have a research group looking at materials to regenerate tooth structure, but we're not there yet. So that's very important to understand, because we have to respect teeth. Teeth are the result of an evolutionary process. And if we put any crown, any veneer, any filling, all these things need a specific width, dimension, okay? Which means we have to properly plan the whole thing. So if you have poorly planned cosmetic dentistry, you can do a lot of damage to your teeth. Or I should say, a dentist can do a lot of damage. So we may have to grind the tooth, and here you see me grinding a tooth, but you better have a very good reason for doing that after a thorough diagnostic planning. And yes, it might look minimal because we use silicone keys to see how much we're actually removing for our materials, but still it's an irreversible procedure. Because what I like you to understand as patients is that all dental restorations will experience complications. Nothing lasts forever. That's why we never say this is your final crown. We say this is your definitive crown, because it will change at some point. It could be a filling, could be a veneer, could be an implant. So implants can lose bone in some patients for different reasons, not the topic of today's presentation. Implants can actually lose the whole of integration. You can actually lose the implants. Many times if you have some systemic issues, or if they were not properly placed with a proper protocol, you can have fracture of porcelain, and then you have aesthetic complications as well. So technical complications can be just fractures of components like screws. Screws can fracture. Implants can fracture. So these things happen. And this is a slide that I like to show to my students, because these are 3 publications from very good centers in Europe, looking at the success and survival of single tooth implants. So that's the simplest implant we can do, just one implant for one tooth. And success means 0 complication. So we're looking for success, not survival. That's the number we have to look as academics, as professionals, when we read the literature. So if you look at these very good centers, after 10 years, 2 or 3 out of 10 implants have some form of complication. So imagine now that this number is much higher if the person who's doing the implant is in a practice somewhere, not necessarily trained correctly, or in other circumstances. So complications do happen, and it's not always the fault of the dentist. It's part of the fatigue and the lifetime of restoration. It's almost, I say, if you buy a car, you don't expect to have this car forever. You will change parts, and you will eventually change the car. And the biggest risk factor for us, especially in my discipline of prosthodontics and building up teeth and doing smile makeovers, is people who grind their teeth, because I cannot control that. So the statistics say that some people grind them when they sleep, and that's usually 1 out of 10 people, and they're not aware of that. And 2 to 3 out of 10 people grind their teeth when they're awake. So just they're stressed, and they're in a meeting, and they grind their teeth. And some of them are aware, some of them are not aware. You may wake up with stiff jaws or some headache, and it might be because you're grinding your teeth. So that is something we cannot control, unfortunately, but I do give to my patients that have significant reconstructions a protective bite guard many times, but that is our biggest enemy. And that also leads to more mechanical problems. So porcelain will break, screws may break, and you really have to have very tight maintenance to avoid that. And of course, the other thing that I have to talk about is tourism, medical and dental tourism. And this slide from the Lancet 2015 actually shows the global centers, known centers of medical and dental tourism. Why is it a big thing? Well, I think it's a growing market globally, driven mainly by cost. So people are looking for something cheaper because they cannot afford to do it where they live. Usually that means Western world, higher socioeconomic levels, and because of the disparity and the big problems with cost of living, some people say, I need to fix my teeth, but I cannot do it where I live. And also availability. If you have to wait for weeks or months or years to do something on a waiting list, rather than just go and do it somewhere else, that's also an issue. So you can see from these graphs that dental tourism is a big global trend, and the market will keep growing. This is kind of a rough map that I drew of where some of the dental tourism flows in Europe. You can see from the UK flows to Spain, Central Europe, Turkey. From Italy, it might go to Croatia or Turkey, and from Central Europe going to Eastern Europe. So this is reality today. This is how it happens. So the problem is that if you have poor planning, cheap materials, which sometimes are used, not always, but sometimes are used to lower the prices, quick treatments, and I did say before that that's a big problem with dentistry and medicine. Biology needs time, but dental tourism means you have to do everything very quickly. And also the lack of aftercare and maintenance can really lead to expensive and serious issues and complications. And this was a British Dental Association survey done recently, and many dentists were complaining about the problems that people had with their teeth. And coming back as clients of dental tourism with many, many problems that couldn't be sorted out. They couldn't go back. And the big problem was some of these people have extensive dental work done on previously healthy teeth for a smile makeover, whereas they could have done something else which is different and more conservative, because they don't realize that any significant dental intervention will require a lifetime of costly maintenance. So dental tourism, I just looked this hashtag on Instagram 3 days ago. It has 208K posts, so it's a big thing, but people do it. We have to recognize that. And the General Dental Council here in the UK has a very nice brochure for patients who are thinking of doing that, with some advice and some pitfalls they have to be careful about. So if you want to scan this QR code, it will take you to the PDF of the GDC, and I think that's some good advice. Because the other thing I have to discuss and make sure you understand in the audience is that dental implants are not teeth. Okay? They don't look like teeth. They haven't evolved like teeth, not even the same materials. They're just not teeth. They don't have the same innervation. They're not teeth. They may feel like teeth. They may function like teeth, but they're not teeth. And the way I'm trying to make people understand this, and my patients, is I say, if you look at the Paralympics and you see these amazing athletes who may have lost 1 or 2 lower limbs, they actually run faster than I can, much faster. So they can function maybe better than I can. But are these their legs? No, they're not. Would they probably wish they had their legs? Probably yes. So the whole idea is, please do not remove good teeth to place implants, because they're not like teeth. Okay. And so please be aware of statements such as implants are a permanent solution, replace your teeth with implants, they feel and function like teeth, they're better than teeth, same-day teeth, all on 4, all on 6. Now, don't get me wrong. Same-day teeth, all on 4, all on 6, can be a very good treatment for specific patients. I do it as well. But it has to be planned carefully. There has to be a lot of discussion with the patient, as I will show you in a few slides. There has to be a full understanding and consent of what this involves, and especially the long-term maintenance and complications. because nobody talks about that. Because dental implants are pretty much like other medically implantable device, being a hip replacement or a breast implant, and they can have problems. And the problems then need revisiting. Okay, so you might break your crown, break your screws, and then somebody has to manage that. And it is important to ask your dentist, of course, they know better, to use reputable and serviceable brands and give you an implant passport, or at least make sure that they have on the records all the information about this implant. Because right now, there are over 600 implant manufacturers globally. We don't even know the exact number. It's hidden. Nobody talks about it. But can you imagine, this is 600 different implant systems, and they vary in almost everything. So to make it, again, the way I explain to my patients is, if you have a car and you need it repaired, but you have no idea what the car brand is. You don't know exactly what the brand is. Nobody told you, you have no paperwork, and you go to the mechanic and you say, can you please service my engine or change this part? But I don't know what my car is. But the mechanic doesn't know, has no idea what tools to use, has no idea what parts to order, from where to service your car. It's exactly the same with a dental implant. We can guess sometimes, but many times we cannot. So you have a patient here who visited me at some point in the past who had implants placed in different parts of the world, and they now need servicing because they have a number of complications, but had no idea or could not get the information about the implants. And that kind of ties my hands, unfortunately, and it's very sad. So that's another topic that is very close to my heart. We have published, but we also keep publishing. So these are two very recent, actually, dissertations, which we're actually now almost submitting for publication. They're in the pipeline. So we're very proud of also what our students do within their programs and the research that we produce from the Eastman. And the last part that I want to mention is this concept of shared decision-making and long-term maintenance. And this is really the relationship between the dentist or medical professional and the patient. So this is a very nice article describing this. So I took the pictures from there. There's different old, let's say, approaches. The one approach that is still valid, is still being done in many areas of the world, is that the dentist or the medical professional is God. And whatever they say will happen because they're so experienced, they have a big ego, and there's no discussion. That's when it will happen. And it still happens in many parts of the world, by the way. Then there is the other model. So that's the paternalistic model. Then there is the other model where some information is given to the patient, and the patient can go think about themselves, Google a little bit, ask their friends, come back and say, I want this. So both of these approaches have some shortcomings. Where we're heading now, and that's how I've been practicing for many, many years actually, is this concept of shared decision-making. So yes, you bring in the experience of the clinician and the authority and the training and the expertise and the evidence, but you work with your patient and you have a lot of discussion, not just once, on multiple occasions, to have proper consent. So the patient understands exactly what needs to happen, understands the pros and cons, the investment in time, the investment in money, and also the most important part, the long-term maintenance. So it's pretty much these three circles, and they have a common shared decision-making part in the middle. Okay, and this was another very nice recent publication from in the British Dental Journal of some people who are also from the Eastman. We like to be in the forefront of things, and pretty much saying that it is a problem because patients are not properly informed that removing some of their enamel or dentin for cosmetic procedures can lead to irreversible damage and long-term maintenance. Okay, so this is very, very important to have. So my message to you is talk to your dentist. Okay, talk to your dentist. Don't hesitate. Ask the questions. Express your wishes and preferences. And that's also for medical professionals, by the way. Ask about pros and cons of treatments. And one thing I can say, I can definitely reassure you, there's never one-way treatment. There are always at least two solutions for any problem. There's never one solution, okay? And anybody who says that is not practicing to a high level. And then ask about the long-term complications and the aftercare, because it does exist. And you buy an expensive car, you will have expensive maintenance. As long as you're aware of that and what this means and how often, that is fine, but it has to be consent. Everybody talks about the now and not the future. So I tried to kind of talk about these topics in the time that I had today. I hope that I shared some messages and some things that I believe patients should understand on both implants and smile makeovers and tooth replacement instead of where we are today in 2024, the technology that we have, but also the problems that exist either in the things that we do or the communication. And with that, I'm ready to go, hopefully having some questions. I'd like to thank you very much for your attention and looking forward to see what people want to ask. Thank you.
Lambis, thank you very much for an insightful lecture. We have some questions. Someone has asked, do you think there's going to be a backlash against the trend of cosmetic dentistry treatment in years to come?
Well, there is a backlash already. I mean, as dental professionals, we see it because obviously we see it either in a hospital setting or in private practice that people come traumatized because of my position, unfortunately. I mean, I love my position, don't get me wrong, Stephen, but because of my position, you know what happens? People and colleagues send you the cases that have gone wrong. And I see many cases that have gone wrong, and they've been to 2, 3, 4 dentists, and now they come to me for the final solution, but they're so tired. They've spent so much money. They've gone through circles and circles, and they're mentally now very tired. And that's the hardest people to treat because you have to just restart everything, re-educate, rejig, and help them, you know, because they've paid a lot of money until now, and now you're the last person on the chain. So we see that there is a backlash. You just don't hear it. We have lawsuits, we have litigation, all that is happening more in some countries than in other countries, yes, but it's out there. We see it all the time as professionals, unfortunately.
Okay, thank you. Someone's asked, what is 4-6X?
Yeah, so I was mentioning there are quite a few dental centers where the only thing they do is they say teeth in a day, we replace your teeth with implants. You go in with some of your teeth, and the plan is that they will take out all of your teeth, your natural teeth, place 4 to 6 implants. X means there could be more implants. It's an X number of implants. And then on the same day, give you back artificial teeth, like the ones I showed you, on implants. As a treatment concept, it's actually very advanced and very good for some particular patients. It's actually indicated. The problem is some of these centers, that's all they do. And the problem with bias of dentists is once you do something and you make good money, and you then do it for the money, not because the patient needs it, that can create a problem. So that's why I try to stress that this is a good treatment for some patients, but it's not for everyone. And you have to know the caveats and the long-term maintenance. That's where communication comes in. That's where consent comes in. And sometimes that is not there. I'm not just talking about the UK. I'm talking globally now.
Okay. Another one is asking, when you go along the high street, you see sometimes the practice says specializing in implants, and other times it says specialist in implants or prosthodontics. How is the patient going to know?
Well, that's a good question, and it's a very hard answer from the patient perspective. So first of all, let me say that there is no specialty of dental implants anywhere in the world. Nobody can say I'm a specialist in dental implants. Dental implants is just a tool that we have to treat patients. So you can do dental implants as a general dentist. You don't need to be a specialist to do dental implants. And some general dentists do a pretty good job, I have to say, okay? The problem is when people do dental implants without any adequate training, because it's a fad, it's a nice thing, and it lures patient, etc. Of course, the more complex a treatment becomes and the more teeth are involved, or maybe it's just 1 or 2 teeth in the front and highly cosmetic, I think you should be looking at more years of experience and maybe more training. So as I said, the prosthodontist is trained exactly for that. Let's say he or she is the architect of the mouth, how this has to be reconstructed. But you can find good treatment with many colleagues. You don't have to be a specialist necessarily. It's just that for the complex things, hopefully even a general dentist will refer you to a specialist at some point. But I understand it's not easy as a patient to look at that. I would say maybe Google your doctor, look at the CV, kind of see what they've done. Even that can be confusing sometimes. So for me, the best patients I get are word of mouth, actually, because the patient is happy, they say to the next patient, that's a good doctor.
I suppose it's like buying a car, you know, the places to go and the places not to go. Someone's been asking, do undergraduates get trained in implants and things like that? Or is it something that's only done specialists and postgraduate?
So I think in most, not all though, in most undergraduate curriculums in the world, there is some form of dental implant training. In some places, it's just theoretical. So you don't touch, you don't see anything, you just read about it. In some places, you actually help somebody else do something and you kind of see you're there as a assistant, as an undergraduate student. And in some places, you may actually even make a crown on some of these implants while you're an undergraduate student. So it depends which university, which town, which country.
But they're really not going to get much training, are they?
No, I mean the 5 years of dentistry that is most countries have 5 years of dental school. It's really not enough. There's so much information. You really have to do more. Like a medical doctor, you cannot even be a GP if you just do medical school. You have to do more training to become a GP.
Someone's asked, why is implantology so expensive?
Good question. So there are two things. One is that some of the reputable companies, which some people may want to use because, as I said, they can be serviceable, reputable, and you have continuity of care, have more expensive components. But it's not just that. It's also the fact that there are many things that may go wrong maintenance-wise or may need to be redone, and that has to be factored in when the price is set. Also, as you very well know, depending on where you go, which town, which city, which neighborhood, which country, prices are totally different because cost of living is totally different. Not just in dentistry, in every service imaginable, from the architect to the plumber, to the hairdresser. So it's the same thing, you know, but you will find, obviously, depending on the expertise and depending on where people practice, differences in price. That is true.
Okay, the organizers have told me to remind people that if they want to ask Lambis questions, they go to Slido and they put in hashtag dental implants, by the way. Someone has asked, how long does it train to actually be good at implantology?
That's a hard question. Okay, so what I tell my students, you can get training in a few months or a few years of surgical training and do the prosthetic part. But the most important part, which we as prosthodontists do, is the planning. So people forget about the planning. The actual placement of a dental implant, in some instances, is not that difficult. But to plan whether you need a dental implant or not, that takes training and it takes experience. And that's why we try to teach our students. Because imagine if you're building a home, you can put one brick over the other and the cement and nothing, but without an architectural plan, kind of blind. Okay, we're going to do a wall here. That's how it is if you're starting doing work in the mouth, cosmetic dentistry, implants, without proper planning. That's where problems happen. It's usually in the planning stage. That takes time and experience. That's what you sometimes pay for with a specific clinician.
Someone's asked, in the past, people used to have partial dentures. Are partial dentures now dead and gone?
No, they're not. I still do removable partial dentures or full dentures for my patients. Obviously, today I had to talk about advances and pitfalls, so I didn't touch on the more conventional old types of treatments. But when I say old, it's because they've been around. For some people, that is actually what is indicated, to have a removable partial denture. And then the discussion is, do they want that for psychological or functional reasons? Can they tolerate it? That's the concern of the discussion. So no, absolutely, we do all these things.
But do they still teach in undergraduate programs?
Yes, less so, but that's not because they're old. That's because there's so much information in the curriculum, and that's why I say you need more training after you finish your dental or medical school.
Okay. Someone's asked, is the cost of implants going to fall, the care, or is it always going to remain quite high?
So again, it really depends, and that's how dental tourism works. It really depends where you practice. So you can get similar, let's say, brand of dental implant, more expensive or less expensive depending on the cost of living or the place that you're seeing the dentist. But what you don't get is the planning and the execution and the thought process and the experience of the dentist. That's what you cannot control. So should they get cheaper? I think yes. With time, they have got a little bit cheaper, I have to say, because of these digital workflows. We do things with high productivity, and that allows us to drop some prices. But as with everything, dentistry is another service, things have gone up. So the cost of materials might go down in some aspects, but the whole expense thing of cost of living goes up globally.
Okay, one more question. Is there other studies showing that implants make people happier?
Okay, so if we talk about happy meaning happy puppy, no. If we talk about quality of life, yes. We have studies, a lot of studies showing that in the patients who I showed with dentures, if you place that minimum, let's say 2 implants on a lower denture, that completely transforms the quality of life of the patient because it doesn't come out anymore. They can eat and they can function and they're happy and they feel psychologically much better. Now, for those bigger cases, of course, from a failing dentition to go to a dentition where you have something stable in your mouth and looks nice, feels like you can speak and function and eat, absolutely. Again, the issue is understanding what this means long term and to expect the complications. The same way I like the analogy of a car, because my teachers, when I was a student, used the same analogy. You do expect to do the service maintenance, change the engine parts, and at some point change the car.
Okay, thank you. So I will wrap this one up today. But first of all, Lambis, thank you very much for your presentation. You present it in a manner such that everyone should be able to understand, including me, who knows very little about prosthodontics. We also realize that in this present climate, prosthodontics and implantology is important for some, but for the majority of individuals, they need routine dental care, and Lambis and his colleagues provide that as well. We realize also that there's a need for dental care for the rest of for the whole population, and we and others are making representation to the funding agencies, to the government, to try and improve that. So we consider everything. But Lambis, thank you very much.
Thank you.
This is the next lunchtime lecture is going to be given, I think, in April, and it's going to be undertaken by Professor Ben Bradford. Ben is in the Department of Security and Crime Science in the Faculty of Engineering, and his topic will be really in a contrast to that of Lambis, and it's on the ethic and racial disproportionality in police use of tasers. And this just does reflect the power, the influence of UCL, that we've gone from prosthodontics, oral health care, along to an issue which is very important to other aspects of our lives. Lambis, thank you very much. I'd also like to thank Alice and Matt for all the organisation of today. So thank you very much. Thank you.